Hi friends, this is Dr. Puja Dewan, your gynecologist for the day today. And the topic is the much awaited hot topic, problematic postmenopausal bleeding, that is bleeding which occurs after menopause. So what is menopause? 1 year of not bleeding is menopause. But if bleeding happens even once, for one instant, which is even a spot, it has to be taken with alertness. You have to be suspicious, you cannot ignore it, you must go and see the doctor. But why? 5% of the women who present in our OPD after menopause have the problem of postmenopausal bleeding. But the problem here is 10% of those who present with postmenopausal bleeding have a risk of endometrial cancer, uterus cancer. Don't panic, but don't ignore. So what are the causes? So what can be the presentation? You could simply have a pink spotting, brown spotting, you could have a regular period, you could have a less than regular period, a heavy period, and even bleeding after sexual intercourse called as postcoital bleeding. You may be confused. Is the bleeding from the vagina, or is it from urine, or is it from the backside? Well, it could be a bleeding which is coming from the urine because of urine infection or because of any tumor in your urinary bladder or a stone which is hitting. Equally, it could be a piles or a hemorrhoid or a fissure or even tumor of the rectum of anus on the backside. But you don't have to worry about it. You don't have to fix the diagnosis. You visit your gynecologist at the right time and everything will be sorted out. So what does your gynecologist offer to you? But before that, are all the women who undergo postmenopausal bleeding are at the same risk for developing uterus cancer as others? No. There is a high risk profile. Those who have hypertension, high BP, obesity, thyroid problem and diabetes. The HOD metabolic syndrome, which is the biggest risk factor. But there can be smokers, there can be those who did not ever give childbirth, those who had early menarche, started periods early, late menopause, and those who are suffering from polycystic ovarian syndrome and ovulatory bleeding. So what are the causes? The causes, as I explained to you, mainly stem out of the dryness, the atrophy of the lining of the vagina, which can lead to vaginal atrophy, and mostly so because of the uterus dryness, endometrial lining becoming very thin, which is endometrial atrophy. 45% of the women who bleed don't have a problem other than endometrial atrophy. When a cut happens, it is because of dryness, it swells and it bleeds, with or without trauma, with or without sex. 10% can have an overgrowth of the endometrial lining called as endometrial polyp. 10% can have a tumor, that is fibroid of the submucous fibroid location again, and 15% can just have thickening of the uterus lining, that is endometrial hyperplasia. This hyperplasia can be simple or complex with or without atypia, leading to risk of cancer. If you have simple hyperplasia without atypia, risk is only 1%, but simple hyperplasia with atypia, risk is 8%. Complex hyperplasia without atypia, risk is 3%. But the most horrifying is complex hyperplasia with atypia with a 29% chance of developing endometrial cancer. And then of course there are 10% who have endometrial cancer, frank and neat at the very presentation. There can be other causes, that we were taking HRT, we took it irregularly, or we could be having irregular bleeding during the hormone replacement. We could be on blood thinning medicines and that were in excess dose, therefore we started bleeding. We could be taking medicines to keep breast cancer at bay after being treated, that is tamoxifen, and because of that the uterus lining became thick. Now what does the doctor do? The doctor takes your weight, blood pressure, assesses your thyroid profile, examines you from your tummy and from outside down below. They put a speculum, look at the cervix, that is the mouth of the uterus, for any infection, erosion, polyp, cancer, growth. Vagina again for any discharge, trauma, cut, infection, growth, polyp. Then they do a bimanual pervaginal examination to assess the size of the uterus, normal or increased, the size of the ovaries, normal or increased. Then comes the step of an ultrasound. Abdominal ultrasound alone is insufficient. Mandatory to do an internal transvaginal pelvic ultrasound. So we can see the uterus lining, endometrial lining, whether it is thick, thin or adequate for menopause. Any lining which is 4 mm or lesser is fine in menopause. If it's pencil thin 2 to 3 mm, that means there is endometrial atrophy. If it is more than 4 mm, that means there is endometrial hyperplasia. Now, does this lining look smooth, irregular, bumpy? Does it have an overgrowth polyp? Does it have a submucous fibroid? It can all be seen. Is there a fibroid in any other location in the uterus body? Does the ovary have a cyst or a growth or a tumor? Because besides the uterus cancer, there can be an ovarian cancer or an ovarian tumor, fallopian tube cancer, cervical cancer, vaginal cancer, vulval cancer as causative agents. If the lining is thick, as an office procedure, particularly in those high risk patients, we can simply do a pipelle biopsy. That is, put a very thin plastic tube in the OPD itself, painlessly inside the uterus, and suck out the tissue. 98% specificity of picking up the diagnosis, 85 to 95% sensitivity. But the gold standard is to put a telescope inside the uterus, that is hysteroscopy with dilatation and curettage, that is DNC. Hysteroscopy with DNC. DNC alone does not suffice. It's a blind procedure. You can't see anything inside. You put the telescope from the vagina into the mouth of the uterus, into the uterus itself. You can see all the walls. You can visualize all the growths. You can treat at the same instance too. If there is a polyp, remove the polyp. You have done a hysteroscopic polypectomy. If there is a fibroid, remove the fibroid. You have done a hysteroscopic myomectomy. If the lining thickness is irregular, biopsy that irregular point and also curate out the rest of the lining. If it's a smoothly thickened uterus lining, curate out everything. Send it for tissue analysis to the histopathology doctor. You will get the answer: cancerous, non-cancerous, hormonal changes, complex or simple hyperplasia, or frank cancer, and the treatment further begins. So now let's look at the treatment. If it was just the vaginal atrophy, we can simply apply estrogen creams and it's over as treatment. But if it is the endometrium atrophy, you can apply the creams plus give some systemic estrogen progesterone tablets to increase the thickness to do away with it. If it's a polyp or a fibroid, we have removed it on hysteroscopy. If it is a cancer, we need to refer to a gynaecologist, cancer specialist, to remove not just the uterus but the ovaries along with some portion of vagina and lymph node biopsy. We might need additional investigations of CT and MRI to figure out the invasiveness of this particular cancer, the spread, staging and growth, and accordingly need for radiotherapy after the surgery. If it's a simplex or a complex hyperplasia, we can remove the uterus with both the ovaries. So remember, simply removing the uterus without doing a DNC is no good. A DNC without a hysteroscopy is no good. Removing a uterus without removing the ovaries in a menopausal woman is also incomplete surgery. And just removing the uterus with the ovaries and no other lymph node biopsy or removal of other parts as sampling is also incomplete treatment. If you were taking tamoxifen, you can stop it. If you were on a higher dose of blood thinner, reduce it and monitor it. This is a very informative, pertinent video. I hope you gained knowledge through this. This is me, Dr. Puja Dewan, your gynecologist, ending the show here. If you like this video, do subscribe to my channel, write a comment, share it with others. Thank you.